Good evening and welcome you all to the today's discussion on questions and answer session. There are some several questions will be our question scenario. That is, question scenario will be we have, and then we have some answers. So you have to pick up the best answers of this question scenario. So today it is 8th class of this type, that is question answer session of the cardiovascular system, and we have some scenarios actually, and we will have to just find out the best answers. So let us start. First question or scenario is about a 59-year-old man is started on lisinopril after being found to have an average blood pressure of 155/93 millimeter mercury, ambulatory blood pressure monitoring. Around 2 weeks after starting treatment, he presents with a persistent dry cough, accumulation of which one of the following proteins is responsible for this. It shows questions. It's very easy question actually. At first, we have to know what is lisinopril. Lisinopril is a group of AC inhibitor, angiotensin converting enzyme inhibitors. Actually, it blocks the ACE, that is angiotensin converting enzyme, and this enzyme is actually responsible for the conversion of the angiotensin and gen 1 to angiotensin 2 actually. So now let us see actually how the following proteins actually. There are 5 answers here, that is adenosine, histamine, bradykinin, acetylcholine, and neurokinin A. So we have to find out the best answers or the right answer here. So if we see the slide here, there is bradykinin is a substance or protein that actually produced, or that is actually produced in increased amount due to AC inhibitors. If we use AC inhibitors, so there is a AC inhibitors usually break down the bradykinin. AC enzyme usually break down the bradykinin, as well as it actually acts on the angiotensin 1. And if we block the conversion of the angiotensin 1 to angiotensin 2 by AC inhibitors, that also blocks the breakdown of the bradykinin actually. So there is increased accumulation of the bradykinin in the lung epithelium, and this bradykinin actually stimulates some receptors, and it also acts through some others mediators like prostaglandins, leukotrienes, and histamine also. So this bradykinin actually stimulates the J receptors, as well as it stimulates some other mediators that actually causes the cough, that is dry cough actually, and it is not responding to any cough suppressive agents or any antibiotics actually. So the only way to stop this dry cough is actually to develop the AC inhibitors, and instead of AC inhibitors, in that case in that case actually ARB, angiotensin receptor blocker, should be used, or any other drugs that is more appropriate for that patient should be actually initiated, and or the dose of the AC inhibitor may be reduced. That may help in some instance, or we have to follow up further actually to a certain period, so that this cough may be actually gradually relieved or gradually stopped, maybe stopped. So how actually bradykinin causes the cough? This is the way of mechanism, and this is the actually the way bradykinin actually increases in the lung epithelium. We all know that angiotensinogen is converted to angiotensin 1 by renin from the kidney actually in the kidney epithelium, and angiotensin 1 is converted to angiotensin 2. And these angiotensin 2 have some many other effects, some detrimental effects actually. But if we use AC inhibitor, actually angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. And if we use the inhibitors of this angiotensin converting enzyme, this angiotensin converting enzyme also acts on the bradykinin to break down the bradykinin to some inactive metabolites. But if we use or block the AC, then we actually, as well as we block angiotensin 1, as well as we also block the conversion of the bradykinin to inactive metabolites. So bradykinin concentration is increased in the lung epithelium, and that causes actually the dry cough. So this is the mechanism how actually bradykinin is formed in increased amount, and that actually causes the cough also. And this is the slide that describes the actually how angiotensin 2 is formed from the angiotensinogen. Angiotensinogen is actually synthesized in the liver, and from this angiotensinogen, when it comes to the kidney, renin from the kidney actually this transform the angiotensinogen to angiotensin 1. And when this angiotensin 1 is passes through the lung epithelium, then the AC inhibitor that presents in the lung endothelium actually, that actually converts angiotensin 1 to angiotensin 2. Then angiotensin 2 has a lot of effects. It stimulates the ADH secretion, it causes the arterial vasoconstriction, it stimulates the adrenal cortex to release the aldosterone secretion. It also stimulates the absorption of the sodium and other substances from the kidney tubules, and it also increases the increased sympathetic drive, and that causes the vasoconstriction that actually increases the blood pressure also, and in various ways actually it causes some detrimental effects on the body actually. So by blocking the conversion of angiotensin receptor blocker, or by blocking the angiotensin converting enzyme inhibitors, we can get some beneficial effects, and these beneficial effects. But when we use the inhibitor, that also breaks down the bradykinin into inactive metabolites. But when we use the angiotensin converting enzyme inhibitors, and that blocks the angiotensin converting enzyme, and that actually cannot block the conversion of the bradykinin into inactive metabolites. So bradykinin level in the lung endothelium is increased, and that causes the stimulation of the J receptors, and it also stimulates the some other factors also that causes the actually dry cough. So what should be the answer here? So among these 5 points, so bradykinin and histamine, these are the close to the answers of this question. But bradykinin actually, this is the actually final answers. Actually, that causes the persistent dry cough. So now we move to the another questions. The man with an extensive enteromyocardial infarction, the last question we have already discussed in the last class, that undergoes coronary angiography is found to have coronary artery disease, which features on angiography predicts the best outcome improvements with coronary artery bypass graft surgery. So actually, what are the best outcome or improvements factor? Among the 4 actually scenario that described below, which one is the in which cases we can get the best outcome or best improvements if we do coronary artery bypass surgery? In which cases it shows the best result actually? So we know some factors like diabetes mellitus. In that cases, actually we get best result from the CABG. Diffuse 3-vessel coronary artery disease, that's another factor from which we can get the best result. Late mainstem stenosis, this is also a factor from which we can get the best result from the bypass surgery, and significant late ventricular systolic dysfunction. That is also an important point. So these 4 important points actually fits best to have a very good result from the coronary artery bypass surgery. And then another question, just to go through. several proximal disease of the left anterdescending coronary artery. Yes, that's a point. In three vessel coronary artery disease with good left ventricular function. If we have three vessel coronary disease with LV systolic dysfunction, in that cases we may have some good results. Two vessel coronary artery disease. But among these four answers here, actually A is the best answers, and that's diabetes mellitus with diffuse three vessel coronary artery disease, left main stem stenosis, and significant left ventricular systolic dysfunction. Actually, this is the best answers. Actually, if a patient have this diabetes mellitus or diffuse three vessel coronary artery disease or left main stenosis or significant left ventricular systolic dysfunction, and in that cases, actually, we can get the best result from the CVZ. So A is the best answers there. Now we go to the next questions. A 76-year-old gentleman is admitted through the emergency department with worsening shortness of breath and ankle swelling on the background of left ventricular failure, secondary to ischemic heart disease. That is, this 76-year senior citizen is coming to the emergency department with the features of shortness of breath with ankle swelling, and this patient actually have left ventricular dysfunction. So left ventricular systolic dysfunction or left ventricular failure due to ischemic heart disease. This patient now have the symptomatics, and that symptom, that is shortness of breath and ankle swelling. That is the actually presentation of the left ventricular failure. So he has also the bilateral basal clefts on auscultation, a raised ABP of 4 cm with the peripheral feeding edema to his knees. He is commenced on IV furosemide. So to relieve his symptoms, actually, he was treated with IV diuretics like furosemide. What is the mechanism of action of the furosemide? So here the questions, just it is easy questions, easy answer to know. That is the mechanism of action of the furosemide. So there are 5 answers there. Inhibition of the sodium chloride transporter in the distal convoluted tubule. This is the aldosterone antagonist. Inhibition of the sodium potassium 2-chloride co-transporter in the thick ascending lip of loop of Henle. Inhibition of the sodium potassium 2-chloride co-transporter of the proximal tubule, and inhibition of the sodium channels in the collecting tubule. Actually, what should be the answer here? We all know that furosemide is called loop diuretics. We all know that. So why it is called loop diuretics? Because it acts on the loop of Henle. So the answer should be loop of Henle. So there are some proximal tubules, the thick ascending limb of loop of Henle. So only this C answer has the loop of Henle. So now we see the actually where it works. The furosemide, a loop diuretics, inhibits water reabsorption in the nephron by blocking the sodium potassium chloride co-transporter in the thick ascending limb of loop of Henle. So actually this is the mechanism. So here we see the mechanism. We all see the sodium potassium 2-chloride co-transport here that acts on the loop diuretics. And this is actually the loop diuretics. This causes the ascending limb of loop of Henle actually. So this is the site of action of the loop diuretics. That is the ascending limb of loop of Henle. Where it acts on the sodium potassium chloride co-transport. So it inhibits the co-transport. So it inhibits the water reabsorption. When it inhibits the sodium reabsorption, so along with sodium, that is water is also reabsorbed, as sodium is not reabsorbed. So this is the mechanism of action of the furosemide. That is one of the loop diuretics, and it acts on the actually loop of Henle. So answer C is the correct answer here. Inhibition of the sodium potassium 2-chloride co-transporter in the thick ascending limb of loop of Henle. So this is the answer, exact answer here. So this is the actually answer. This is the loop of Henle. This is the ascending limb. This is the descending limb. So this is the ascending limb where loop diuretics works. So this is the where actually the loop diuretics acts. We all know that the thiazide acts on the convoluted tubule in which active transport in the cortical diluting segment of the ascending loop of Henle. Potassium spondylitis actually inhibits the sodium in the distal convoluted and collecting tubule. Loop diuretics that inhibits the ascending loop of Henle. So this is the site actually where several diuretics actually acts, and these diuretics are acts in different sites actually of the kidney function, that is kidney unit, that is nephron, in different parts of the nephron. So now we move to the another answer. In patients with a pericardial effusion, what is the most important clinical sign to determine whether there is a cardiac tamponade? So this is the discussion about the cardiac tamponade on a patient having pericardial effusion. So pericardial effusion, if a patient have pericardial effusion, so he or she may not have cardiac tamponade. If this pericardial effusion is developed rapidly, or there is a large amount of pericardial fluid is accumulated, in that case, actually cardiac tamponade may occur. So, what are actually the following clinical sign that can indicate the patient has cardiac tamponade? The points here are cyanosis, hematuria, peripheral edema, pulsus paradoxus, and raised JPP. Actually, among these 5 signs, pulsus paradoxus is the answer. When pulsus paradoxus is present with a patient with pericardial effusion, in that case, it's actually we can be sure, or we can suspect this patient may have cardiac tamponade, and in that cases we have to do actually we have to just find out, but we have to confirm the pulsus the cardiac tamponade. And if patient has cardiac tamponade, then actually that's a cardiac emergency, and we have to treat the patient in emergency basis. So cardiac tamponade clinical features to look for: then patient may have sinus tachycardia, even in the absence of frank hypotension, elevated jugular venous pressure, pulsus paradoxus, pericardial rub, and Kussmaul sign. These are the features of cardiac tamponade actually. And there are some triad also. This is called Beck triad. Usually we found this Beck triad in the patient with cardiac tamponade. This is increased jugular venous pressure, hypotension, and diminished heart sound. And patient also may have pulsus paradoxus. What is pulsus paradoxus? That is greater than normally not 10 millimeter up to 10 millimeter in respiratory decline. Is possible in systolic arterial pressure, but if it is more than 10 millimeter mercury with inspiration, that is called pulsus paradoxus. Kussmaul sign. What is Kussmaul sign? Paradoxical increasing venous pressure during inspiration, and you worsen the area of dullness with bronchial bass sounds and bronchophony below the angle of the left ischium. This is the features of the actually pericardial effusion as well as cardiac tamponade patient may have. So the answer, what should be the answer? The answer should be here, D, that is pulsus paradoxus is the appropriate answer. That is the clinical sign that is the feature of cardiac tamponade patient. So now we move to another question. The following medical treatments are all associated with improved symptoms in patient with heart failure due to left ventricular systolic dysfunction. However, which of the treatments has not been shown to also improve survival? We all know that if a patient with left ventricular with reduced ejection fraction, that is systolic heart failure, that is a high mortality rate. That is, even we know that there is a 50% mortality, 5-year 50% mortality, or for survival, 5-year survival is 50%. Even a patient with heart failure is more in a danger than a patient having cancer in various aspects. So it is more dangerous than a patient having cancer, because some cancers may have 5-year mortality only 5 to 10 or 20, 30%. But a patient with heart failure, if we not treated properly, this patient may have survival rate is 50%, and 5-year survival rate is 50% only. So we have to know that there are several treatments to treat the left ventricular function, but there may not have been, some drugs may improve the symptoms, but this patient may have no role in the actually long-term survival actually. So there are 5 options here: bisoprolol, enalapril, furosemide, sacubitril valsartan, and spironolactone. We all know that beta blocker is bisoprolol, enalapril, that is ACE inhibitor, furosemide, diuretics, sacubitril valsartan, that is Entresto, or this combination, and spironolactone. Among these 5 drugs, the bisoprolol, enalapril, that is beta blocker, ACE inhibitor, sacubitril valsartan, that is ARNI, that is called also ARNI, and spironolactone. These 4 drugs has definite survival benefit, but furosemide, that is a very important drug to control the symptoms in a patient with heart failure. But this furosemide has got no actually survival benefit with a patient, though it is a very effective drug to reduce the shortness of breath or reduce the symptoms due to heart failure. But this drug don't have any long-term survival benefit. So among these 5 answers, C is the answer here. That is furosemide, that is the diuretics. Though this drugs has got symptomatic improvement or symptomatic relief, it is a very crucial role, but this patient don't have any, this drug actually don't have any survival benefit with a patient with late ventricular systolic dysfunction actually. So from this slide, we can see that drugs that reduce mortality in heart failure would reduce ejection fraction. We all see the angiotensin receptor blocker or angiotensin that is ACE inhibitor, here also seen beta blocker and mineralocorticoid antagonist. And the rest of the thing is that ARNI. We all know that these 4 drugs, along 4 groups of drugs, along with ARNI, that actually have the mortality reduction benefit. That is, it causes the reduced mortality and morbidity also. Also, it reduces the hospital readmission also in the different ratios actually. It decreases. So now we move to another question. Which of the following antiplatelet drugs is an phosphodiesterase inhibitor? So we all know that there are several antiplatelets groups that acts to inhibit the platelet aggregation as well as platelet activation. And so they act in the different site of action of the platelets. So their mechanism of action in the different ways. Some are actually inhibit the platelet receptor on the platelet site or platelet surface, and some inhibit actually the mechanism within the cells, and some inhibit the the aggregation of the platelets. So there are several mechanisms of actions of antiplatelet drugs. And here we see that there are 5 antiplatelet drugs: cangrelol, clopidogrel, dipyrimidol, dipyramidol, dipyridamol, and prasugrel, and ticagrelol. There are some antiplatelet drugs. Now let us see where actually they act or they function. Here we see that there are some phosphodiesterase inhibitors, like dipyridamol, that inhibits the phosphodiesterase 5. That dipyridamol, sildenafil, vardanafil, tadalafil, and japrinast, and then so on. So even methylgenthins also. So they act by inhibiting the phosphodiesterase inhibitors. So actually, we already have get the answers. So dipyridamol, that is C, is the actually answers that inhibits the phosphodiesterase enzyme, that is phosphodiesterase inhibitors. That's so. And the other phosphodiesterase inhibitors are sildenafil, vardanafil, and tadalafil. We know that these drugs are actually used to treat the different, to reduce the pulmonary hypertension, to the pulmonary pressures, and also these drugs are used in the erectile dysfunction also. So actually, this is the mechanism of actions of some drugs, but among these 5 drugs, dipyrimidol, that actually inhibits the phosphodiesterase. So dipyrimidol, this is the answer here. So now we move to another question. A 54-year-old security guard who is obese and enjoys Drinking alcohol and cigarette smoking with his friends has a diet high in saturated fats. Is that acute myocardial infarction, which lifestyle risk factor has the strongest association with myocardial infarction? So, which lifestyle risk factor has the strongest with the myocardial infarction? So, he has drinking alcohol and cigarette smoking, and also has the high diet in saturated fats. So which one is? It is excess alcohol, it is high saturated fat diet, it is obesity, already the man has sedentary activity as is a security guard, so the patient is a sedentary lifestyle and smoking. Among these five, these are actually all the five factors that are actually involved with the myocardial infarction. But among these five factors, we have to find out which one is the strongest association with the myocardial infarction. So here actually excess alcohol, high saturated fat diet, obesity, sedentary activity, smoking. So among these five things, I think the high saturated fat diet and obesity, sedentary activity is one of the strongest actually lifestyle risk factor for myocardial infarction. Now we move to another question. A 36-year-old smoker has sudden onset of chest pain whilst out walking in a remote island of Scotland. He attends the local hospital, is found to have ST segment elevated myocardial infarction. Which treatment has the strongest time-dependent benefit that the quicker received, the better the outcome for the ST segment elevated myocardial infarction? So this is the about the treatment of the patient having ST segment elevated myocardial infarction, that is STEMI. Aspirin, beta blocker, heparin, Parkinson's corner intervention, tissue-plasminogen activator. Actually, tissue plasminogen activator and also PCI, that also this actually to have the benefit, the quicker receive, the better the outcome. Tissue plasminogen activator or that is thrombolytics actually, or PCI. So actually has sudden onset of chest pain whilst walking in a remote island of Scotland. He attends a local hospital, is found to have ST segment myocardial infarction. So probably as the remote island of Scotland, that is far away from the all facilities or good facilities of treatment like Parkinson's corner intervention, most likely this is not available or cath lab is not available in their center. That is the remote in the Scotland. So the question is asked here, that is among the available treatment, which one has the best outcome if we receive earlier? So in that case, tissue plasminogen activator, that is, it is one of the thrombolytics, and this thrombolytics actually it is the very mass beneficial, and in that case actually when there is a PCI is not available actually. So the answer will be the tissue plasminogen activator. So I think I can stop here today, and we can discuss several questions in the next class actually. Good night and stay safe, stay blessed. Thank you very much with being with me. Thank you.